Many thanks to the executive producers, in particular David and Nina Fialco, Diana Barrett, Bob Vila, and the other executive producers and folks at Impact Partners who helped to bring this really magnificent film to the screen to allow us to be able to tell this story. And thanks so many of you for taking some time from your evenings to share and to allow us to tell this story to you. My name is Dr. Gary Gottlieb. I have the privilege of being the CEO of Partners in Health. And as the final screen saw, the Partners in Health is now functioning in about 10 countries with the privilege of taking care of, in partnership with their governments, more than 7.5 million people. And in each of those places, our function is to partner with government, to accompany government, and to be able to try to create sustainable solutions to improve healthcare outcomes. I have the privilege of being involved with this organization for about the past 15 years, although I've been the CEO for the last 2 years. Just as I was starting as the president of the Brigham and Women's Hospital in 2002, Paul was working with Dr. Victor Zhao, who was then the chairman of medicine, to develop a division of global health equity. He was actually also working with one of the brilliant professors of the Brigham, Dr. Jerry Avorn, who's here to develop a sustaining and terrific division of pharmacoeconomics, which is a leader in its field. And I quickly fell in love with Paul and with the mission, and worked with Victor and Paul to recruit Jim back from the World Health Organization, where he was working in the 3x5 HIV program before the Global Fund and before PEPFAR, and joined the board in 2005. I was in Rwanda in 2008. And when I became the CEO of the Partners Healthcare System, the parent of the Brigham and the Mass General, in 2010, about 12 days later, was the earthquake in Haiti, and I had the privilege of going down about 2 weeks later to be able to work with folks down there as we were trying to bring resources and to support the people that PIH, the Brigham, and then the General as it was bringing people and material down there to be able to provide support. So I've been kind of in love with the thing for a long period of time, and somehow or other, about 2 years ago when Vineyard decided to step down, the glow and the halo of this remarkable mission to truly provide a preferential option for the poor, meaning that each one of us, no matter which zip code we happen to be born in, is entitled to the same great good for our families, for ourselves, and for our hope and for our futures, has drawn me into this. And it has been a remarkable privilege. Part of that privilege is being able to work with exceptional young people. And one of the stars of this film who had a walk-on, you may have seen at the University of, at HUM, the Hospital of University at Marsh, Dr. Reagan Marsh, who is an emergency physician at the Brigham, who in fact started the emergency service at that hospital in Marsh, which has become probably the country's busiest trauma center by a major factor, and the country's very first emergency medicine residency program. So really building a sustainable pipeline of exceptional people in her shadow who can in fact do this work long into the future in their own country and be able to teach others to do so. She was also, when we jumped into the fire in West Africa, in Sierra Leone and Liberia, she was one of those people in those protective garments who was in an Ebola treatment unit as she ultimately became the medical director of our program in Sierra Leone. So I wanted to introduce her to you, and maybe she can give you a few words about what drew her to this kind of work.
Complicated question. Thank you. I just want to echo the same thanks for spending your evening with us and watching the movie and supporting us in all the different ways you do. I feel incredibly fortunate. I think I have the greatest job in the world. I have the privilege to work at Harvard Medical School, to teach residents and medical students at the Brigham in the emergency department, and then to spend another portion of my time, everywhere from half to all of it, working with Partners in Health in Malawi and in Haiti, and then ultimately in Sierra Leone. And we have an incredible team, both in our sites. Our patients are really incredible, and so I was drawn into this work because it is your heart and your soul, and the work is incredible. And what we have the privilege with PIH, which I think makes us unique in the NGO world, is sort of a duration of work. We've been in Haiti now for 30 years, in Rwanda for over 10 years, in Malawi for 8 years, and we go into places like Sierra Leone where the situation is horrible after Ebola in West Africa, but we do that with a perspective where after the earthquake in Haiti it seemed horrendous, but we know that with since the earthquake now 7.5 years of investment, we can see a hospital like Mirabalais, and I think that gives us a really unique perspective in development where we can see the impact of sustainable investment in health systems. And so that same sort of devastation that we witnessed in Haiti after the earthquake and now with the hospital at Mirabalais, we're sort of on the same path in Liberia and Sierra Leone. So that is why I do this work.
When part of the emphasis, as Dr. Agnès, who is now the Vice Chancellor of the newly minted University of Global Health Equity, which last month graduated 24 Masters of Global Health students, gave them master's degrees, and we'll have our first medical school class in about the next year and a half in rural Rwanda to create basically fertile soil in the midst of Southeast Africa so that brilliant young people will want to stay there, to be able to build and to be able to build a foundation of pipelines of people who won't be brain drained to Europe, to the United States, or to Asia, but will create the same really kind of soil that we built in Cambridge and Boston 400 years ago that have created the kind of pipelines that we've had. And what you saw, and I think the example of Rwanda, was that a strong health system is the most powerful tonic for being able to prevent horrendous outcomes. And Sierra Leone and Liberia, because of a generation of civil war, places that are in the dust, are in fact medical deserts. In Liberia, there are 45 physicians for about 4.7 million people. That's the equivalent of about 7 doctors in Boston. I have 3 in my family. And so the notion of building consistent human capital as well as the other infrastructure has to be part of this. And that was really the vision of Mirabalais. To be able to, I think we have now 5 residency programs at Mirabalais, another one that's in St. Mark, that all of which over the next few years will try to get the same kind of accreditation at an international level, ACGMEI accreditation, that we have for our residency programs here, so that they become, in a long-term way, the ability to build kind of a foundation in that way. So it is remarkable work, but I can't imagine a greater privilege that people inviting us into their homes at their most frail moments, at times of uncertainty and fear, to be able to somehow reach out with our hands and to bring skills and resources we have from elsewhere to be able to help them and their families. And to also tap on the genius in these communities. Community health workers are just an extraordinary technology. The notion of people who know their communities, who know what's going on, who know all the secret handshakes, and also can find their way back into the homes of people and ensure trust to be able to give people medicines that are pretty scary. You know, you saw Melquiades, and he's been with us in a variety of places, and is now an advocate for bringing resources to the treatment of MDR-TB. The average person with multi-drug resistant tuberculosis takes about 11,000 pills over the course of 2 years, and they are all really toxic. They're horrifying chemotherapies. And the medicine, the illness itself makes people depressed, dysfunctional, apathetic, and skinny, but the medicines make them feel worse. And so the notion of doing that is quite difficult. So we have some time for some questions. We'd love to hear from people. Microphone.
Yeah, I'll take it around. Is it possible that your organization could do something to help healthcare delivery in this country?
Well, so we work in a number of programs in this country. We have a program in the Navajo Nation, and now with Rosebud Sioux Tribe in South Dakota. There, we're really providing technical assistance to bring some of the same kinds of resources. So in the Navajo Nation, we actually have a CDC grant and a grant from PCOR, one of the other federal agencies that focuses on 2 major areas. One, in the treatment of non-communicable diseases, so having community health workers be able to screen people for hypertension, diabetes, teach about nutrition, and also for mental illness, substance use. and depression, and also to be able to provide prescription for fresh foods and to work on nutritional outcomes there. But working with about 540 community health workers that are part of the Navajo Nation, which has most of its own funding to provide health services in lieu of the Indian Health Service. It has a special provision to do that and has worked with us. And we're kind of starting from scratch with a much smaller tribe, the Rosebud, which is in South Dakota, which is proximal to a really dysfunctional IHS hospital that's in provisional accreditation, and trying to work with them to provide assistance and resources to try to change the healthcare system there. We've also had a very small program that focused on HIV in Boston that has leveraged a wider scale training of community health workers in a variety of other places. But in general, our work is not in this country. Yes.
Is this working? In most products, if you lower the price, you sell more of it. Why is it that these drugs could cost $20,000 when somebody presents Africa and said, okay, look, you could sell 30,000 packages of this medicine. Why does the price have to stay so high? I mean, is it cost that much to make it? Is it that difficult to make it, or is this just kind of driven by sort of Western markets that they don't want to drop the price down to an affordable price for Africa?
So as you notice, one of the things that Jim did after a little bit of research was to realize that a bunch of those drugs were off patent, and that allowed further negotiation of those prices.
So that's a different issue,
but,
though, if it's a patented medicine.
Right. So the drugs that have patent protection, companies essentially want to both protect the research that they've done in terms of the amortization of that research, as well as have varying levels of willingness to share the intellectual property. Many will, in fact, create various kinds of different arrangements in developing countries where the protections against that intellectual property are reduced, as long as they have some protections that the drugs aren't easily able to be black marketed. So if there's observed treatment, they're willing to in fact sell those drugs, some of them at lower rates. Clearly, when government funds became available through PEPFAR and the Global Fund, there was substantial negotiating power, and that reduced the price of those drugs as well.
You have a question here?
Excuse me, not a question, but a giant thank you. This was just a beautiful, exquisitely thoughtful, difficult movie, I'm sure, to make, and you did a fabulous job. And my question is, what's next for the film itself?
So are there any impact partners who would like to discuss that, or Nina?
There is a whole impact campaign that is happening around the film, and one of our big goals is community screenings. We're hoping to have between 500 and 1,000 community screenings across the country to really get the message about Partners in Health and the great worldwide work they're doing out to people. So we will let you know, and we hope that people will be feeling excited to get involved with community screenings and support the work. So, and Diana had to add something to add.
And very specifically, we have a gap of $35,000 for those screenings this fall in both New York and Boston. We've actually raised a lot of money, but we need $35,000 very specifically. So if any of you are feeling, well, how do they do it? They send money, you know. Go to the website. Just go to the website. Go to the website. But this is the way to get it to as many people as possible, as fast as possible, to get the film out there so people can really feel a sense of involvement.
Okay, one last question. We have Jill up here in the front.
One of the most shocking things about the film was seeing George Bush, and that he was such a breakthrough president for the work that you do. And then you obviously had Obama, and he was very supportive. What are you expecting over the next 4 years?
Reagan, why don't you answer that question? Clearly, there are
It's a serious
concerns,
question.
right? I mean, in the way that foreign aid has been teed up at the present time in the budget that was presented, there are clearly concerns about continued support in some of these areas. The funds in the Global Fund are multilateral, and pretty much they've been committed in a 3-year cycle, so they shouldn't be threatened. There have been some questions or tests as to some of the funding around PEPFAR that have been raised, but are not line items in the budget. I think one of the real worries, we don't get a substantial amount of money directly from USAID, which is the largest funder of aid. Probably about 70% of foreign aid comes from USAID. Much of it comes out of rural sectors into urban sectors and not in the corridors in which we operate. And a lot of it's for trainings, kind of Todd's comment about the PowerPoints, and for other kinds of infrastructure work. The challenge is that a lot of these countries have very modest GDP. So if there's a substantial reduction in foreign aid, it'll be destabilizing for those countries in terms of their ability to govern and to be able to have funds. And that will be challenging to us. I mean, we've seen in Sierra Leone, DFID, which is the British federal aid program that helped to fund our work in Ebola, and then has continued to provide aid in Sierra Leone. Pretty much right after Brexit, we started to see a reduction, and a very substantial reduction in expected funds. They were halved twice, and basically those resources that were supposed to be for health system strengthening kind of disappeared, or were made pretty minuscule. So we would have some concern about that.
Yeah. Well, yeah, go ahead. Let's comment.
This to me is why PH is here, right? To me, part of the reason, there are lots of reasons I work for PH, but the part that I love about us is that we are at the intersection of activism and science, right? And so we know what it takes to make people well, right? We know how to invest in HIV systems, in TB systems, in primary care, in building health systems and hospitals, and we know the outcomes associated with it, right? That's the science. And then what I think PIH does in a way that is unique and different compared to a lot of NGOs is puts it out there, right? And that is our roots, right? With TB, with HIV, and I think now in the time of Trump, this becomes even more important to say who we are and what we stand for, and to take these cuts in government funding from USAID, from DFID, and to declare this as an unacceptable state of affairs, and we will have to raise more money from the private sector, we will have to raise more money from the corporate sector. But to me, this is why we are here and what we do, and it's in these times where I think we as an organization become best, right? Because it's these challenges that we face. And so I assume my politics identify with yours. We were all upset, right? But I feel like now is when, this is when we have to come together as a community and really advocate for our patients and what we do, both domestically and abroad. So.
Yeah.
To that point, basically, we believe the principle of this organization is that healthcare is a human right. What Inez described for Rwanda, which is basically the policy that we advocated for globally, is universal health coverage. And that is the notion of whether to make certain that there's the availability of healthcare services and that there's a spectrum of how much individuals have to participate in payment. Those who have no funds could be exonerated, those who participate up to the affordability, and that's the way it works in Rwanda, and that's kind of the paradigm that's been put forward. The notion of being able to remove the coverage of care of the poor in this country that was implemented when I was 10 years old, and that has been part of the cornerstone of delivering those services, along those principles would be calamitous. Be calamitous here, and following those same principles would be dramatically difficult elsewhere. And frankly, given the United States really, to some extent, leveraging aid elsewhere to be able to have that vision and to drive that forward, it would make it extremely difficult in those places, and the outcomes could be horrific. And I think that that's fair. And as Reagan points out, basically we're essentially dependent on philanthropy. PH always has had about 70 or 80% of its budget focused on philanthropy because it's given us the ability to make decisions, to make choices that haven't been bound by restrictions. They've been bound by our partnership with local governments in order to be able to find solutions. And that's the challenge we face, but it's also the opportunity that we have because of those freedoms. So.
Well, thank you, everybody.